Harlan Krumholz, editor of JACC, professor of medicine at Yale. I'm here with another professor of medicine at Yale, Ania Jastreboff, one of the leaders in obesity medicine throughout the world, and a terrific doc, great clinician, good and person, and a wonderful researcher. Look, Ania, here's a question people have. Is there such thing as healthy obesity? I mean, are there people with obesity whose blood pressure is fine, whose lipids are fine, who we really shouldn't be bothering about cardiovascular risk reduction because their other risk factors are not perturbed, they're not out of whack, they're not high. Is there healthy obesity?
So I think there's a few things in there to think about. First of all, your question, well, is there really healthy obesity? So some patients may carry extra weight, and at least by the BMI definition, which isn't a great definition, right? BMI is a screening tool. They meet the definition of obesity that we have today, and they may not have those metabolic sequelae that you're speaking about, but they may encounter other medical or psychological or psychosocial sequelae. They may have knee pain, or they may have hip pain, or they may have obstructive sleep apnea, or they may have, they may have faced shame and blame or been discriminated against. So there's many, many other things that patients with obesity face that can impact anything from their mental health to their physical function and in terms of their metabolic health. So that's the first thing.
But let me just ask you this, though, because I think this is key to this question, which is, are the adverse effects, the increased risks associated with obesity, all mediated through risk factors that we can discern, like lipids and blood pressure and inflammation? Or is it that obesity itself can, have other pathways? And so for us, it's not letting people off the hook if the traditional risk factors look in line. If they're living with obesity, they're still likely at high risk, let alone for the 200 other conditions associated with obesity, but for the cardiovascular risks. What do we know about that?
Well, I mean, again, I think in terms of having obesity, just because you don't have the downstream effects yet, right, whether it's on the heart or metabolic effects or anything else, doesn't mean that you're not at higher risk for developing them down the road. So, so let's say that you're a person who's 20 years old and has obesity and does not have hypertension. It does not mean that when you are 40, that obesity that you've had for 20 years doesn't predispose you to then develop hypertension when you're 40. Same thing with knee pain or any other obesity related disease. So I think we need to consider what is the health benefit, the long-term health benefit over a lifetime for that individual, and treating early rather than waiting until those downstream negative or those downstream diseases develop.
But I'm going to push you. Are there independent effects of obesity on cardiovascular risk, or are they all mediated through these blood pressure, dyslipidemia? I mean, I think this has been controversial in the past.
You mean in terms of the fat tissue itself and I mean, again, obesity is considered to be an inflammatory state.
Mm-hmm.
So in the same way, so I'll give the example of diabetes. I'm an endocrinologist, so there you go. So when we look at dysglycemia, we're looking at dysglycemia. We're looking at glucose levels. Well, before there's dysglycemia, there's dysregulation in terms of insulin levels, right? So insulin levels initially go up, they're much higher. You don't see any dysglycemia, but is it less normal to have these high insulin levels? I would say yes, right? Because eventually your pancreas gets tired and it can't keep up. So not only do you have high insulin levels, then your blood sugars are no longer controlled. So is there a similar model in terms of cardiovascular health or other metabolic diseases? I would say yes. And, diabetes progressing to, or I would say normal glycemia progressing to prediabetes, and prediabetes in and of itself is a state of risk for micro and macrovascular disease, and then progressing to diabetes, which of course it puts you at higher risk for all of these cardiovascular diseases. It's all a disease progression. So why not treat it early on? Why not treat it before all of these other pre-disease states occur?
Well, let me tell you my frame, and you can tell me whether or not this is right. If I think about this parallel with hypertension, it is true that there's some people with very high levels of blood pressure who never have strokes, never have heart failure, don't have renal disease, don't have downstream sequelae that we can determine. But we've been unable to determine who are these people, just like the people who smoke who may live a long life. What we know is on average it confers risk.
Yes.
And that some of that risk is mediated through different pathways, but we haven't yet figured out exactly if we can identify who is immune from the adverse effects of this, either short-term or long-term. I feel like we're in the same place with obesity, that there may be people whose profile looks good today, but we still haven't determined who exactly might live a long and healthy life despite living with obesity, when we know on average it will confer risk. And like you said, that risk is not just cardiovascular. It can be a wide range of things, including orthopedic issues and beyond cancer risks. But at least in cardiovascular, I'm not sure that we're in a place where we could safely say someone living with obesity is safe from cardiovascular disease.
Yes, I mean, I agree. And again, you can say that for any of the other 200 obesity-related diseases, including certain types of cancer. So the thing is unless you can identify an individual and say, okay, and this individual has absolutely no risk for any of the 200 other obesity-related diseases, but still, then wouldn't you still offer treatment? Right? There are other sequelae that aren't cardiometabolic.
And in a shared decision-making model, you're laying out the pros and cons, and people, according to their risk values and goals, can make decisions. But certainly we should be talking about it. Well, thank you so much. This is great to be with you.
My pleasure.